Hi everyone, welcome back to my YouTube channel. Hope you all are doing well. In today's video, I will go over summary of changes proposed by CMS to Medicare Shared Savings Program and Quality Payment Program for the calendar year 2023. Let's dive right in. On July 7, 2022, the Centers for Medicare and Medicaid Services, or CMS, issued the calendar year 2023 Physician Fee Schedule, or PFS, proposed rule that includes proposed changes to the Medicare Shared Savings Program, or Shared Savings Program, to advance CMS's overall value-based care strategy of growth, alignment, and equity. Through the changes CMS is proposing in this proposed rule, CMS seeks to reverse certain recent trends in the shared savings program. In recent years, growth in the number of beneficiaries assigned to ACOs in the shared savings program has plateaued. Higher spending populations are increasingly underrepresented in the program since the change to regionally adjusted benchmarks. And access to ACOs appears inequitable as shown by data indicating that Black or African American, Hispanic, Asian/Pacific Islander, and American Indian/Alaska Native beneficiaries are less likely to be assigned to a shared savings program ACO than their non-Hispanic white counterparts. Several of the proposals CMS is making in this proposed rule are expected to advance equity within the shared savings program. Based on feedback from healthcare providers treating rural and underserved populations that they require upfront capital to make the necessary investments to succeed in accountable care and may also need additional time under a one-sided model before transitioning to performance-based risk, CMS is proposing to provide advanced shared savings payment, referred to as advanced investment payments, to low revenue ACOs inexperienced with performance-based risk Medicare ACO initiatives that are new to the shared savings program, that is not a renewing ACO or a re-entering ACO, and that serve underserved populations. These advanced investment payments would increase when more beneficiaries who are dually eligible for Medicare and Medicaid or who live in areas with high deprivation measured by the Area Deprivation Index, or ADI, or both are assigned to the ACO, and these funds would be available to address the social and other needs of people with Medicare. CMS is also proposing other modifications to certain existing policies under the shared savings program to support organizations new to accountable care by providing greater flexibility in the progression to performance-based risk, allowing these organizations more time to redesign their care processes to be successful under risk arrangements. As CMS seeks to increase the percentage of people with Medicare in accountable care arrangements, CMS is balancing incentives and participation options to serve a dual purpose of sustaining participation by existing ACOs and increasing program growth, recognizing that ACOs vary in their composition of providers/suppliers, the needs of the populations they serve, and have varying degrees of efficiency relative to their region and experience with accountable care initiatives. In this proposed rule, CMS is building on the existing shared savings program benchmarking methodology by proposing modifications to strengthen financial incentives for long-term participation by reducing the impact of ACO's performance on their benchmarks, to address the impact of ACO market penetration on regional expenditures used to adjust and update benchmarks, and to support the business case for ACOs serving high risk and high dually eligible populations to participate, which will help sustain participation and grow the program. Additionally, CMS is proposing modifications to the benchmarking methodology to mitigate bias in regional expenditure calculations that benefits ACOs electing prospective assignment. The changes CMS is proposing to the benchmarking methodology used in the shared savings program would align with their consideration of the more long-term benchmarking concepts that would move toward the use of administratively set benchmarks in order to grow and sustain long-term program participation as discussed in the related request for information, or RFI. CMS is also proposing to expand opportunities for certain low revenue ACOs participating in the basic track to share in savings even if they do not meet the minimum savings rate or MSR to allow for investments in care redesign and quality improvement activities among less capitalized ACOs. CMS is proposing changes to the quality reporting and the quality performance requirements that are responsive to interested parties' feedback and designed to support transition of ACOs to all payer quality measure reporting. These proposals include reinstitution of a sliding scale reflecting an ACO's quality performance for use in determining shared savings for ACOs regardless of how they report quality data, and to revise the approach for determining shared losses for enhanced track ACOs. CMS is proposing to extend the incentive for reporting electronic clinical quality measures or ECQM/MIPS CQMs through performance year 2024 to align with the sunsetting of the CMS web interface reporting option. CMS is also proposing to implement a health equity adjustment to an ACO's quality performance category score to recognize high quality performance by ACOs with high underserved populations. CMS is proposing benchmarking policies to establish quality measure benchmarks and minimum attainment level for the CMS web interface measures for performance years 2022, 2023, and 2024 under the Shared Savings Program. Many of these proposals are the result of their efforts to align policies under the Shared Savings Program and under the Center for Medicare and Medicaid Innovations or Innovation Center ACO models. For example, the proposed advanced investment payments are derived from learnings from the ACO investment model or AIM, an innovation center model that tested the effects of making advanced payments of shared savings to certain ACOs participating in the Shared Savings Program. This proposal to incorporate advanced investment payments into the Shared Savings Program payment methodology is an example of how their larger ACO strategy of having the Innovation Center test new payment and service delivery models on the Shared Savings Program chassis can better harmonize policies across Medicare ACO initiatives and enable them to scale any findings. CMS is also seeking comment on an alternative approach to calculating ACO historical benchmarks that would use administratively set benchmarks that are decoupled from ongoing observed fee-for-schedule spending, including the design of a potential approach as described in the request for information. CMS has observed that the benchmarking methodology for the Shared Savings Program and Innovation Center models may include ratchet effects that reduce benchmarks for successful ACOs and jeopardizes their continued participation over multiple agreement periods, resulting in selective participation, including limited participation by inefficient ACOs. The request for information or RFI seeks to gather information regarding a potential alternative approach to calculating ACO historical benchmarks that would use administratively set benchmarks that are decoupled from ongoing observed fee-for-schedule spending. Finally, CMS is proposing changes that are important for improved operations of the Shared Savings Program, including policies to reduce ACO administrative burden as part of their efforts to balance reducing administrative burden on ACOs with their continued focus on program integrity. While ACOs would continue to have to comply with marketing material requirements, CMS is proposing to eliminate the requirement for an ACO to submit marketing materials to CMS for review and approval prior to disseminating and modifications to streamline the SNF 3-day rule waiver application review process. CMS is also proposing modifications to the beneficiary notification requirements, including to reduce the frequency with which beneficiary information notices are provided to beneficiaries from annually to a minimum of once per agreement period, with a proposed follow-up beneficiary communication serving to promote beneficiary comprehension of the standardized written notice. Further, CMS is proposing to update data sharing regulations to add that ACOs acting as organized healthcare agreements or OHCAs may request aggregate reports and beneficiary identifiable claims data from CMS and indicate ACOs may choose to structure themselves as OHCAs in order to reduce burden with reporting electronic clinical quality measures or ECQM/MIPS CQMs. There will be a 60-day public comment period on this proposed rule. CMS encourages all interested members of the public, including ACOs, providers, suppliers, and Medicare beneficiaries, to submit comments so that CMS can consider them as it develops the final rule. The 60-day comment period closes on September 6, 2022. Comments can be submitted at the website that I have pasted on this slide. In commenting, please refer to file code CMS1770P. Quality Payment Program or QPP Policy Proposals Overview. CMS recognizes the challenges faced by many across the country over the past 2 years. As they move forward together and look to the future of the Quality Payment Program or QPP, the Centers for Medicare and Medicaid Services or CMS remains committed to promoting more meaningful participation for clinicians and ensuring their policies continue to drive them toward value and improved health outcomes for patients. To further these goals under the Merit-Based Incentive Payment System or MIPS, CMS is focusing their proposals on continuing to develop new MIPS value pathways or MVPs and refining the subgroup participation option. MVPs provide clinicians with the opportunity for more meaningful participation by reporting a more connected, cohesive set of measures and activities and allowing for comparative feedback that will be more beneficial to patients. CMS believes that subgroup reporting will allow comprehensive measurement of clinician performance in MIPS due to the ability for a cohort of clinicians to form subgroups and report on measures and activities relevant to the scope of care provided. CMS anticipates that subgroup reporting would allow CMS to capture clinician performance at a more granular level, provide performance feedback to clinicians relevant to their scope of care provided, and provide patients better data to make informed decisions about their care needs. CMS is proposing limited changes in traditional MIPS to provide clinicians continuity and consistency while they gain familiarity with MVPs. For example, CMS is proposing to continue streamlining and strengthening their quality measure and improvement activities inventories by proposing to remove duplicative and topped-out measures as well as those with limited adoption. Maintaining a quality measure inventory that drives quality outcomes for patients is a key goal of quality measure reporting. Meanwhile, the new and modified activities help fill some gaps CMS has identified in the inventory and standardized language related to equity across the category. CMS is also proposing several policies to reduce burden and facilitate participation in alternative payment models or APMs. For example, CMS is proposing to permanently establish the 8% minimum Generally Applicable Nominal Risk standard for Advanced APMs, which is currently set to expire in 2024. CMS also previously finalized a policy to set a limit of 50 on the number of clinicians in an organization that participates in an advanced APM through a medical home model using the medical home model nominal financial risk criteria. At that time, CMS described the way in which they would identify APM entities that meet this standard as looking for APM entities that participate in medical home models and that have 50 or fewer eligible clinicians in the organization through which the entity is owned and operated. CMS defined organizational size as measured based on the size of the parent organization rather than the size of the APM entity itself. In this Notice of Proposed Rulemaking or NPRM, CMS is proposing to apply the 50 eligible clinician limit to the APM entity participating in the medical home model based on the 10/NPIs on the APM entity's participation list. CMS is also proposing conforming changes to their other payer advanced APM policies in these areas. CMS is also issuing the following request for information or RFIs to solicit feedback on the future of the Quality Payment Program or QPP. Payment gap for qualifying APM participants or QPs and subsequent transition to enhanced conversion factor updates RFI. MIPS quality performance category health equity RFI. Developing quality measures that address amputation avoidance in diabetic patients RFI. QCDRs, which stands for Qualified Clinical Data Registries, /QRs /Health IT Vendors supporting all measures in MVPs RFI, continuing medical education or CME organizations submitting improvement activities for MVPs RFI, advancing the Trusted Exchange Framework and Common Agreement or TEFCA RFI, continuing to advance to digital quality measurement and the use of fast healthcare interoperability resources or FHIR in the Quality Payment Program RFI, potential transition to individual QP determination RFI. This is it for today. Thank you for joining me. If you found this information useful, please consider subscribing to my channel and leave me a few comments. Hope to see you next time. Bye now.